This is chapter 14, Secondary Assessment. So we split this up into assessment of trauma and medical patients. And again, we can kind of categorize most of our calls into one of those categories. Some kind of go a little bit of both, but for the most part. So we're going to look at this flowchart style. We do our scene size up, we make sure that we're not going to die, we make sure our crew's safe, the patient's not in initial danger. We do our initial assessment, so we're checking for our general impression, level of consciousness, and our ABCs. And at that point we should know whether we're dealing with trauma or medical. And so we'll go down one of these branches here. And if we decide it's trauma, then we're going to take either one of two paths here. So one where there's a significant mechanism of injury, and a little bit different path when there's a non-significant mechanism of injury. Okay. So when there's a significant MOI, basically we're worried about damage to multiple systems that we may need to find all these different problems. And so we do kind of an overview assessment of the whole body, which is called this rapid trauma assessment. On the other side, if there's not a significant mechanism of injury, so if somebody just twisted their ankle or has some other kind of non-major trauma thing involved, then we can more or less just focus on whatever the injured part is. Okay. I'll go through this in more detail here. So some parts of the secondary assessment, we need to get more focused history and do the appropriate physical exam. So when there's no significant mechanism of injury, again, we're going to focus on whatever that patient is complaining of. If they were walking along and slipped and bumped their knee on something, probably a minor mechanism of injury, and we're just mostly going to look at their knee or whatever they're complaining of. So you still want to pay attention and get some decent history and figure out whether it was truly just accidental slip trip kind of thing versus some kind of medical component to it, where maybe they were feeling dizzy because they had a heart murmur or something, maybe they got dizzy or ataxic because they're drunk or whatever on something else. So always realize that there can be mixed stuff going on. So figure out what exactly happened. Did they get hit with a baseball bat or fall out of a tree or get hit by a car, whatever? Were they wearing any protective equipment? Were they wearing a helmet if they were bicycling, for example? Anything else that happened during the event? They tuck and roll as they fell? Did they put their hands out? And then, probably most importantly, where they're complaining of pain and where they have injuries. So you can kind of sum this all up in the question, what happened? So for the physical exam part, again, what you're looking at depends on injuries and chief complaint. And remember, some of those mechanisms of injury patterns might lead you down certain ways to look for injuries. Basically, we're willing to visibly look at things. We're going to use our hands, press on body parts, that's palpation, and auscultation is listening with a stethoscope. So you'll still see this acronym out there sometimes, this DCAP BTLS stuff. It's kind of an overly cumbersome acronym that just is, anything out of the normal. So I like this shorter one a little better: wounds, tenderness, deformities. That's what you're looking for. So wounds, looks like a bullet wound in this picture. Tenderness, so something feels sore when they move it, tender, painful. And then deformities, like that dude that's probably got a busted arm. So not all deformities are quite that obvious. That's pretty good obvious deformity. So if there's no significant MOI, we're gonna get baseline vital signs, past medical history. We'll do both of these for a significant mechanism of injury too. Just running through it here. So we went through the whole vital signs chapter. So get your vitals. We can separate into signs and symptoms. So signs are objective things. So what you can witness. You can say they had sweaty skin or staggering. You can say they vomited. Versus symptoms are what the patient tells you. So you can't see that somebody has chest pain except that they tell you they have chest pain. You can't see that somebody thinks they're nauseous and might throw up. And they tell you that they're nauseous. That's what they feel. And we'll document both of these things in like our charts we'll talk about in the next chapter. But we just document them in a little bit different places so that we can separate out what's objective and what's subjective information. We'll try and get a sample history. So sample, this is a worthy acronym. You should all memorize this because you're going to see it on quizzes and tests and that kind of thing from here till the end of the class. It's also on the National Registry skills sheets. So the S in sample stands for signs and symptoms. So that one's pretty straightforward. They're going to tell you that you can ask clarifying questions. You ask them if they have any allergies. So this could be both to environmental things and medication allergies. You ask them if they're taking any medications. And you want to know both over-the-counter medications, any kind of herbal supplements or anything like that, and prescription medications. If they're on regular, like daily medications, it's also helpful to know whether they've taken their stuff that day or not. You want to ask about any pertinent past history. So do they have a history of diabetes, heart disease, anything like that. Their last oral intake, so what they had to eat or drink last. And then E, the events leading up to that. So kind of what were they doing or what was going on when whatever happened. So if mechanism of injury indicates We're going to do a C-collar. We have adjustable C-collars, so you can adjust it to the right size for the patient. When you put that C-collar on, it makes it kind of hard to see what's going on underneath, so try and look and make sure there's no major bleeding or anything else going on there. You should tell the patient that the C-collar basically reminds them not to move their neck. It doesn't really prevent them from moving their neck so much. It helps, but you have a C-collar on, you can still crank your neck around a little bit. So they're not terribly comfortable, but they shouldn't be uncomfortable. Don't put it over somebody's ponytail or longer hair. I'm going to put it underneath hair. If they've got larger jewelry, necklaces, larger like big dangly earring, hoop earrings and stuff, usually you gotta take those out or just make sure they're not getting pinched in there. So it's typically a two-person job, one person holding the head, the next person sliding the C-collar in. Again, the C-collar isn't going to prevent all movement of the neck. And so I guess this is a little bit dated now, but we don't always have to go to a long board. If they have any kind of deficits, so tingling, numbness in their fingers, paralysis of any extremities, then you want to go for sure to a long board. If they have major distracting injuries, so like femur fractures, other broken large bones, it's very possible that they won't be necessarily paying attention to that neck pain that they also have. So a large distracting injury, you'd also generally want to go to a backboard. Remind me at the end of this thing, I'll show you our official like C-spine protocol. If they have major altered level of consciousness, you also generally should go to a backboard. Others, if they're too drunk to feel that their neck is broken. Okay, so then down here on the significant MOI side, we got them in a C-collar, we'll do this rapid trauma assessment. So we're still holding their head. If there's that significant MOI, we probably should be maintaining cervical spinal control. Then we're going to do a complete head to toe. So this should be done in 30 seconds-ish. 45 seconds maybe. And in general, we want to do this as soon as we can. There are some exceptions here. So for a rapid trauma assessment, we want to essentially be able to see pretty much the whole body and what we're looking at. So this isn't something you really want to do like when somebody's laying in a snowbank, whatever. So if they're in a car accident or something, today would be a good day to not maybe do this while they're on the side of the road. You might do it en route to the hospital. But if possible, you want to do this as early as you can. So again, we're going to look at the whole body, head to toe. We'll look for our wounds, tenderness, and deformity, not the DCAT BTLS. Tell them what you're doing. Most patients are just fine as long as you explain to them that you're going to do a full body assessment and you're going to be poking and prodding in a bunch of different places. In general, we want to expose injured areas. So if they're complaining of leg pain, we're going to get out our EMT shears and we're going to cut their pant leg up so we can see what their leg looks like. So we're down the significant MOI path. So in general, we're going to be assuming that there's some kind of spinal injury. If you're starting to cut clothes off and you're finding major bleeding or something, go ahead and stop that bleeding when you find it. That says to provide care down there that got cut off. So when you're assessing the head, look for your wounds, tenderness, and deformities. You're also going to look in their ears and nose for CSF. So CSF is kind of a clearish fluid. Check their pupils. Shine a little light in their eyes if you've got a pen light handy. Look for jugular venous distension. You may know what that is. So you got your jugular veins right here, right? So normally when somebody is standing up, walking around, you can't really see jugular veins. If somebody is lying down, there's a fair chance that you will actually see their jugular veins bulge just a little bit. But standing up, you shouldn't see JVD or jugular venous distension, and if you do, that's a sign of some chest trauma or something going on. If you haven't already put on a C-collar, think about putting on a C-collar again. Move down from the head down to the chest. So again, we're going to expose the chest, look what's going on. We're going to look for paradoxical motion. So that's where they have multiple rib fractures, and when they breathe in, and the chest gets bigger, that little section of rib goes the other way, gets in. And then when they're breathing out and their whole chest is getting smaller, that little bit goes out. So that's paradoxical motion. Crepitation is the sound of bones grinding on bones, so like two broken bone ends rubbing together. That sound is crepitation. Whip out your stethoscope real quick and listen for breath sounds. And at this point, unless you suspect some injuries here, you're probably good just doing 2 spots for breath sounds. Just check each side. If you see some injuries, you probably should listen both here and down lower too. And then in the abdomen, we're going to look for a distended abdomen, which isn't a terribly obvious sign. You also want to go ahead and palpate the chest a little bit. And so you're just going to squeeze and push on the sternum a little bit. And that just checks for the ribs all being not broken, basically, and for pain. So again, squeeze on the sides and push on the sternum a little bit. And the abdomen, again, we're going to look for a distended abdomen or an abdomen that's sticking out. And we're going to palpate all 4 quadrants. So we're centered on the belly button. You go 1, 2, 3, 4. Just checking for pain. And down to the pelvis and extremities. So you want to give the pelvis a good squeeze, make sure it's not busted and rocking. Check for male erection or priapism, which is a sign of some nerve damage somewhere. And then look for distal circulation, sensation, and motor function in all our 4 limbs. So In each arm, if they're awake, you're going to have them squeeze your fingers or something. Ask them if they can feel you touching their fingers or toes. And then check circulation. So look for good skin color. Make sure their extremities aren't pale or cyanotic. You can do a little cap refill check. You can check for pulses. It's a little harder to find pedal pulses sometimes. You should be able to feel radial pulses though fairly quickly. That's a good circulation check there. Then as you're rolling your patient to put them on a backboard, I'm going to check their back. And just run a hand down their spine. Make sure that they tell you when you're poking back there if they feel pain. Make sure they're not lying on a beer bottle or beer can or firearm or something else. So I mentioned it at the start of this, but when do we do a focused exam versus the rapid trauma? Anybody?
Focused would be with no significant
No significant MOI, right. Rapid trauma when there is a significant MOI and we want to figure out what's wrong. So your rapid trauma is especially useful on your unconscious patients when they're not complaining of anything because they're unconscious, right? So you need to find their injuries. For kids, realize that they're less developed, so in some ways that prevents injury, in some ways it makes them more susceptible. So things like car accidents, they can be injured more because their little organs aren't as well tied in there, and so they kind of, like that real fast deceleration can cause more like organ tears and stuff. When they're just bouncing around falling, their bones are a little more flexible, so they can be a little bit more resistant like broken bones. So it's both. With the kids, they're probably going to be freaking out, so make sure you're talking to them, you're down on their level, and we're typically going to go feet to head in our order of assessing things instead of head to toe, just because it's a little easier on them if you start with the feet and move up that way, a little less invasive. Okay, and then detailed physical exam. So back here in our flow chart. So this would be after we're in the ambulance and we're essentially on the way to the hospital. And basically we're going to repeat the assessments that we've already done. We're not always going to do this for each patient. It's going to depend on our travel time to the hospital. But we're going to do all of our interventions first. I should say like primary assessment, evaluate it again. So after you've done your rapid trauma assessment and cut their clothes, cover them up with a blanket to keep them warm, if we're doing the detailed physical exam, we're going to expose things again, usually just a part at a time. If you've used splints or any other mobilization things, backboard, etc., we're going to work around that. But basically it's the same as a rapid trauma exam, only this time we're going to do it a little slower. Make sure we didn't miss anything on the first go over.
Would you take a second set of vital signs at that point?
Yep. So is it always necessary to do a detailed assessment on a trauma patient with no significant? No, not necessarily. It's not a horrible idea. But, yeah. Okay. Okay, so done with the trauma side here. So if during our initial assessment we decided this is a medical call now, we'll go down one of these two branches. So if our patient is awake and talking to us and can tell us what's going on, then we'll do a focused physical exam. If they're unresponsive and can't tell us what's going on, we're going to do a rapid physical exam. So again, if they can tell us what's hurt, having chest pain or something, then we'll just assess their chest mostly. For unresponsive medical patients, we're going to have to use our environment and use the a rapid exam to find stuff. So during your secondary assessment of your medical patient, you're going to be talking to them a lot more. This is how you're going to figure out what's going on and what you need to do for them. So we're going to get a history of our present illness, past medical history, do a focused physical exam, get our vitals. So for that history part, it's best to get it from the patient if you can. If they're not able to provide it for some reason, altered mental status, if they're a minor or a kid that doesn't quite know what's going on, that kind of thing, then you can get it from family or bystanders. In general, we like to ask open-ended questions. So not yes, no questions, but things like, how are you feeling? Can you describe the pain? Those kind of questions. So chief complaint, again, this is why they called or why somebody called. And this is just what's bothering them the most. So some of these patients can have multiple problems, but this is the main complaint. When we're interviewing and trying to figure out what exactly is going on, we're asking about their chief complaint, this acronym, the OPQRST, these are the questions we want to ask. So this, along with the sample thing, is another deal that you should memorize, and this will show up on quizzes and tests and more tests and more quizzes. So the O part, what were you doing when it started? So this isn't the time that it started. That's down here at the T. But this is what were you doing. So if they're complaining of chest pain, for example, were they sleeping in bed and the chest pain woke them up? That would be important. Were they working outside shoveling snow, working hard when their chest pain started? Were they just watching TV? So what were they doing when it started? Provokes, so what makes it worse? So if they've got some chest pain or something, does breathing in make it worse? Quality, ask them to describe it. Some of these things are easier to ask for like pain things than other deals. So like if your patient's chief complaint is breathing difficulty, you might ask them how it feels when they're breathing or something like that. They might not be complaining of a pain specifically. The same with radiation. So like if they're complaining of abdominal pain somewhere, that often can radiate. Back pains can radiate places. But again, if it's breathing difficulty doesn't really radiate. You can ask them if anything else is painful, that kind of thing, for that question. And then severity, so how bad is the pain? We give it on a 1 to 10 scale. Like 10 is the worst pain. You can either say like 10 is the worst pain you can imagine or the worst pain you've ever felt. I don't know. Ask them to put it on a 1 to 10. These patients, if they've had some kind of chronic pain, are pretty familiar with the 1 to 10 pain scale. That's pretty standard across healthcare. And finally, T, the time, when exactly did the pain start? So like 6 a.m. this morning or 2 a.m. or whatever, just hours. You also want to get a sample history from these medical patients. Some of these things are going to overlap just a little bit. So again, signs and symptoms, it's pretty much their chief complaint. But allergies, medications, pertinent past history, last oral intake, and events, these are all different, largely different questions than your OPQRST. I guess events is pretty similar to onset. So when they tell you what their chief complaint is, then you should ask some follow-up questions regarding that specific complaint. So if their complaint is something related to diabetes or something, you probably want to ask, if they've checked their sugar recently, checked their blood sugar level recently, can you check it again? Have they ever had this happen to them? They take insulin for it, have they taken their insulin? Those kind of things. If they're complaining of breathing difficulty, you can ask about inhaler prescriptions, history of asthma, things that seem appropriate to that complaint. Again, just think about what body system is involved and ask questions about that. So then where it's appropriate, you'll do your focused physical exam. So chest pain or breathing difficulties, you're going to whip out your stethoscope, listen to lung sounds. If they're complaining of abdominal pain, then you want to look at their abdomen and palpate their abdomen. Things like chronic back pain, you probably want to palpate along their spine. Complaint is something like altered level of consciousness because they're diabetic. There's not really something to examine there. You can do a blood sugar check. There isn't really a body part to look at for like diabetic calls. Get your vital signs. Just mentioned this, but someone's complaining of shortness of breath, look at the chest, listen for lung sounds. Okay, so that was down the responsive side. Now if we go down the unresponsive side, so you may not have a chief complaint in this case, or the chief complaint might be what somebody else is telling you. So you're gonna need to do a pretty thorough physical exam and get vitals. And do a rapid assessment of their entire body. So it's pretty rare that there isn't at least somebody there telling you something that's going on. So you should at least have some kind of history. So this rapid physical exam is basically the same thing as our rapid trauma assessment. So run through from head to toe. Looking for JVD, look especially for medical identification devices, so any kind of jewelry that indicates their cardiac history, breathing problems, allergies to certain things, whether they're diabetic or not. All these things can be found on some medical jewelry. Look and see if they've been incontinent. Any indications that they've had a seizure. Check for pulse. You're not going to be able to check motor function and sensation terribly well if they're unresponsive because they can't tell them to wiggle their fingers or if they can feel you touching stuff. You can check for a painful response, but you may or may not get that. Look for medical identification devices. Again, look for bracelets, anything that indicates what medical problems they might have. Figure out pretty quickly if you want ALS to come. Get on the radio and call for a paramedic, or for a way out in the county somewhere. Maybe it's going to be quicker to just get a helicopter to come land. Talk to bystanders. If the patient's unconscious, somebody call 911. So, see what you can figure out. Obviously, name, date of birth is good to have. What happened? Try and get your sample questions answered by the. Excuse me, by the reporting party. So besides bystanders, how else can you gather information about what might have happened?
Assessing the scene, like if there's shattered glass or a fire from a car, you might think, oh,
Yep.
car accident.
Yep. Any signs of trauma and stuff like furniture toppled over, that kind of thing, sure, yep. You can find their medications, prescriptions lying around, that might tip you in. You find insulin in their fridge, that kind of thing, yeah.
I know like a lot of smartphones have like the feature of like being able to check the first responders and stuff. How often do we use that here?
Not terribly frequently, but yes, it is a place you should check if they have a phone line on them. Yeah, I don't know how many people will bother to put that information in there, but I would expect that most people that have chronic illnesses, diabetes, and that kind of thing probably would put it in their phones.
So,
Yeah. Good. Yeah. Okay, and then reassessment. Basically, we're gonna redo our initial assessments and keep retaking vitals and make sure that our patient isn't getting worse on us. So again, we'd like to document improvement, vital signs getting better, hopefully not getting worse. Keep up good communication with your patient throughout the whole process. Make sure that you're just telling them what's going on. If you can do assessments in a a more private area where appropriate, that's good. In the back of the ambulance is more private than on the street corner. During the reassessment, make sure nothing else has gone terribly wrong, see how their mental state is doing, keep talking to them, make sure your airway is open, keep checking your ABCs, pay attention to skin color, if anything is changed, reassess what you're doing for them. Take vitals again. Make sure you don't need to turn up their oxygen or turn it down. When we're given oxygen, we're more or less titrating to effect, so we want a number between like 95 and 100 on our SpO2. If you get it up to 100, you might consider dialing back the oxygen just a little bit because we don't want to supersaturate them. Just like people having a stroke and MIs, if they're having a heart attack, they don't recover as well. Their long-term recovery process is worse if you've given them too much oxygen. So titrate to effect, get them between 95 and 100. If you were doing a focused assessment, so if they were complaining of any specific injury, then you can recheck that specific injury. If you've applied splints to anything, then make sure that you didn't put on your splint too tight. It's reasonably easy to like bandage things too tight or splint things too tight and cut off circulation to fingertips and that kind of thing. So just make sure that you didn't accidentally do one of those things. If you put them on a backboard, they're probably going to start feeling some back pain by the time you get them to the hospital. But excessive back pain means maybe they're laying on something or something isn't positioned quite right. Repeat your focused assessment or physical exam as appropriate. If you were controlling bleeding, make sure that it's still controlled, not bleeding through. Make sure you don't need to add more bandages to something. Write down all your vitals. If you see blood pressure going down the tubes or something, maybe you need to more aggressively manage whatever it is you're doing. So for your stable patient, you probably only need to reassess every 10 to 15 minutes. For your less stable patient, every 5 minutes is more appropriate. Yeah. So your stable patient in this 15-minute interval is probably the one you're doing like a long transport on, like maybe taking somebody from here down to Lewiston or from here up to Kootenai or Spokane or something. Most of our transport times are like 5 or 10 minutes. The furthest out we get is maybe 20 minutes or something. So. Questions on that one? Secondary assessment.